Are people coming in, Show? I can see a few people.
Yeah, I think people who with a link can just join the meeting, so we don't have to admit anyone in.
Fantastic.
So feel free to start when you'd like.
Okay, well, thank you, and welcome everyone to this London Tobacco Alliance London Smoking and Mental Health Week webinar, which is going to talk about smoking, mental health, and particularly lung health, and some of the issues around accessing diagnosis and treatment for this group of people. And when we talk about smoking, we are always, of course, we have inequalities very firmly in our sights. And for people with severe mental illness, who are much more likely to smoke, as we know, that link into lung health and lung cancer and outcomes from that is really important for us to have a focus. So we've got a really great selection of different speakers today. We're going to have a panel discussion at the end, and we're delighted that you're here and that you've joined us. Please do follow us on LinkedIn. There will be stuff going on to LinkedIn for the London Tobacco Alliance there. And a very warm welcome. And thank you to all the people on the call who've helped make this happen. And I'm going to hand over to Ed now to introduce the session more from his clinical perspective. Thanks, Ed.
Thank you, Tracy. So good afternoon, everybody. It's brilliant to be here and really excited to be in the middle of the second London Mental Health and Smoking Week after we did our inaugural one last year. So really good to be doing this again and really moving on the conversation from the one we had last year. I am a medical director at CNWL, NHS Foundation Trust. So I'm based in North London at the moment, although was until recently in North Central London. I'm also presidential lead for physical health at the Royal College of Psychiatrists, although only till next week because my term ends with our current president, Laddie Smith. So I'll be very sad to give that up, but it's been a very, very busy 3 years. And as of this year, I'm the co-chair of the Mental Health and Smoking Partnership. So really excited to have that opportunity to take forward the work that we've been doing on smoke-free and all of those related topics. It has been a very busy year in the world of smoke-free, I would say. Probably the main highlight is the Tobacco and Vapes Act now having passed. So it now has royal assent, and we're moving on to the phase of implementing the new legislation, which is a massive opportunity to push improved public health, because it's a really significant piece of public health law, which we've not had one of for quite a while, actually. So I think we will be working all together on how that gets implemented. We've also had the launch of the Smoke-Free Action Coalition Pledge for a Smoke-Free UK, which was around the same time as the Tobacco and Vapes Act received its royal assent, which I think was a coincidence, but it felt like it shouldn't be one. So there's a lot of momentum and a lot of organisations looking to work together to lead to a country where no one starts smoking and the prevalence goes down further and further and further. So in terms of the focus for this week, I suppose we want to focus on the link between mental health and smoking, but I suppose what's different about this year is that we're starting to think about how we prevent harm from people for people who have smoked or do smoke. So as well as helping people to stop, we're thinking a bit more about what can we do to support people to mitigate the potential effects of smoking as well. We know from the most recent data that was published recently from the Office for Health Improvement and Disparities that 50% of early deaths of people with severe mental illness are from cardiovascular disease, and one of the key drivers of cardiovascular disease is smoking. We also know that lung disease and cancer are significantly are big drivers of early death in people with severe mental health conditions. And I'm sorry to start talking about that at the beginning of the webinar, but I just think it's really important to orient ourselves to the issue that we're dealing with. We know that people with mental health conditions are more likely to smoke, as Tracy has said, and less likely to get support to stop. But actually, I think the reason we're all here is because we don't want that to continue, because I, and I'm sure others, really want to make sure that people who have a mental health condition or neurodiversity or some combination of mental health related issues do have access to stopping smoking support and to early treatment for the complications of smoking, because frankly, they deserve it the same as everybody else. So I'm really keen for us to think together about how we continue to expedite access to stop smoking support, and there's loads of ways that people can do that, but also that we think about how we make sure everybody has the best access to screening and treatment for conditions like lung cancer. So we're really going to focus a bit on the lung health elements of the issue today. And we've got a really good programme. It was just on the slides a little moment ago, but we've got some really fantastic people. I can vouch for nearly all of them because I've worked with them before, who have some really interesting things to say about what we're doing at the moment and what we can do, what others can do moving forward. And you know, the thing that's really stands out for me over the past year or two is the way in which people are really thinking about equity and good access to the sort of support that everybody needs. So I think we're in a really good position to drive things forward. So I'll just let you look at the programme there for a second. The next item is going to be a video because, and I'll introduce that in a moment. We're going to talk about cancer screening, and we're going to hear from Gracie and from Amy, who have done some brilliant work around improving access to that. We're going to hear from Meria from Oxley's around what the tobacco dependence team are doing there around prescribing, and really excited that Samantha and Ian from Rethink are here to talk about some lived experience roundtables that they were involved in. And we've got some time at the end to have a discussion between us about what comes up during the course of the webinar. Really pleased that we're recording it so that you can share it in your networks, because it will be very, very, very unmissable content, in my humble opinion. So without further ado, I suggest we move on to the next item, which I will tell you a little bit about before we play the video. And the reason we're playing a video is because because Adam, who is will introduce himself on the video, but who is an oncologist who works in diagnosis for lung cancer, is away somewhere exotic, unfortunately, so he can't be here. But he was very, very kind and recorded an interview between the two of us, which we're going to watch a bit of now. I first worked with Adam on a roundtable and report that is now publicly available, supported by Bristol Myers Squibb and the Health Service Journal, and involving colleagues from Rethink, including Sam, who's on the call. And what we were looking at was thinking about what are the inequities or inequalities around not just screening, but also diagnosis for lung cancer, on the basis that people with mental health problems tend to miss out on both of those. And we'll say a little bit more about that in the interview. The report comes up with a range of different recommendations. Some of them are around policy, some of them around practice. I'm a bit biased because I was one of the contributors, but I think it's really good. And actually, it gives us a real focus around how we can use perhaps lung cancer and lung cancer screening to learn more about other disease areas that affect our population disproportionately as well. So I'm going to hand over, I think John is going to put the video up for us, but that's just a bit of a background. And I will let him put the video on, and I'll probably turn my camera off and hide in the corner because I don't like watching myself on videos, but please enjoy. My name's Ed Beveridge. I'm a psychiatrist and a medical director in North West London, and I've got a long-standing interest in improving health of people with mental health conditions. And it's really exciting to be here to talk about the topic of lung cancer screening and diagnosis, and I'd like to introduce Adam.
Hi, yes, my name's Adam Januszewski. I'm a consultant oncologist and I care for patients with lung cancer. And over the last few years, I've been involved with trying to reduce some of the inequalities in access in treatments for patients with lung cancer. And that's why kind of individuals with mental health conditions are so important, because we know that that there is such a large variation in care access.
And we worked together on a report that's now publicly available, and that was looking at improving diagnosis of lung cancer in with particularly severe mental health conditions. And it's produced a number of really, really good recommendations.
Not only are they practical recommendations for on the job if you work with individuals with mental health, but also system level recommendations on how to redesign or think about designing services to enable us to provide the best outcomes for individuals with mental illness and potential diagnosis of lung cancer.
Can you say a bit about what's your part of the pathway for lung cancer?
Lung cancer is really exciting to work in at the moment, because we've seen such great advances both in the screening, the diagnosis and the treatments for lung cancer. And the issue around inequalities is becoming even more important, because while we're getting better treatments and outcomes, we don't want that inequalities gap to widen. And that's where we were involved in kind of bringing together a group of experts from across the UK to look at some of that data around the inequalities in access and outcomes for patients with lung cancer. And what we could see is that those individuals with severe mental illness have some of the lowest outcomes or poorest outcomes compared to their compatriots that don't have mental illness.
My understanding is that people with severe mental illness, so things like schizophrenia or bipolar disorder, don't get diagnosed early enough to get good outcomes. Is that right?
What we know is that diagnosing early improves outcomes. When we look, and that's why the lung cancer screening program has been rolled out over the last 2 to 3 years. What we've seen in some of that data is that around 3/4 of patients that are diagnosed with lung cancer through the screening pathway are diagnosed with stage 1 or 2, which means they're able to have curative intent treatment. Now, when you look outside of the screening pathway, only around 1/3 of patients are diagnosed with early stage lung cancer. When we look at the proportion of patients with severe mental illness, they are more likely to be diagnosed either through the emergency route or indeed with a more advanced disease, which means that we can't offer radical or curative intent treatments for those individuals.
But the other thing that occurs to me is, of course, preventing smoking or stopping smoking is probably the upstream intervention that we really need to make sure that people have access to. And I think this is a lot of what the work that I've been doing is looking at as well, and clearly getting people screened earlier so that they can come into treatment at a stage where their cancer is treatable. Say somebody has symptoms suggestive of lung cancer, what would their pathway through to diagnosis look like?
So in order to be diagnosed with lung cancer, there are in general 2 pathways. As we've spoken about, there's the screening pathway. If you are between 55 and 74 and you've ever had a smoking history, whether that's current or previous, then and you're registered with the GP, then you're invited to what was called a lung health check. That involved a series of questions about lifestyle and risk factors. And then if you meet certain criteria, you'll be invited for a CT scan. And then the results go back to the patient, and all being well, then they'll continue in that program. Every 2 years, they'll be invited back to that.
There isn't very much by way of recalling people who don't turn up to screening, I think.
Lung cancer is one of the conditions or malignancies that has the greatest impact around inequalities, but also affects the most diverse and deprived communities in the UK, is that there's been a real proactive approach to try and reach out to engage with all of the deprived and diverse communities in the UK, but they've not looked at those individuals with mental health conditions. And I've always said, if you can design a pathway for either the most deprived, diverse individuals with mental health conditions, if you can design a pathway for those individuals, actually it makes it better for all people.
From your clinical experience, what's it like for people with a, say, a severe mental health condition coming into a diagnostic pathway? What happens to someone in that position?
Lung cancer is really complicated. In order to get a diagnosis of lung cancer, there are so many steps, from scans to biopsies to lung function to meeting different doctors, nurses, physicians, to go through that without a condition of mental health illness is complicated in itself. What we know is that because of the increased likelihood of developing more advanced lung cancer, our diagnostic threshold should really be lower for individuals with mental health conditions. And so we shouldn't really be saying come back, and if it's not gone away within 2 weeks, we should really be kind of moving on and through that diagnostic pathway. But then there's serial appointments after appointments and scans after biopsies, which if you get through right to the end, it is actually an achievement in itself. And what we often find is that the engagement and the attending of all those appointments is more difficult because each of those appointments is a barrier in itself, and people drop off and don't engage the more tests. And what you know is that sometimes people don't understand how important every single one of those steps is, because if you don't do every one of those steps, I can't give you a formal diagnosis and treatment plan. And I think one of the things that we really need to work on is trying to educate, upskill clinicians that work in the lung cancer field, so that there aren't those preconceptions, so that we give patients with mental illness the best treatments with the support that's required.
Those preconceptions we know aren't true, because if you speak to people with lived experience, there's no evidence that they don't want the same treatment options as everybody else. If you look at smoking cessation treatment, for example, the evidence around that is that people with mental health conditions want to stop smoking, will engage with support if it's designed for them, and will be successful in quitting. And I think one of the messages that I think it's really helpful for us to put across is the fact that, you know, everyone wants access to the right treatment for what they have.
Yeah, and it's about clinicians that work within the lung cancer kind of pathway, whether that's the diagnostic or the treatment pathway. I think we have a lack of confidence and understanding about how to care for patients with mental health conditions. So I think there's a need to improve that understanding. I think there's a need to work together more closely.
And when you start having those conversations between you, everyone really wants them, you know, so it's not just us two, but actually as soon as you start discussing your patients with people from different parts of the system, everyone really wants to do that, because it will get better outcomes for the people that we work with.
Language is really important, particularly in patients with a potential diagnosis of lung cancer. But my fear is that for individuals with mental health illness, that labeling this as a cancer check may create barriers that it doesn't need to, because actually it's about raising awareness around well-being, around your lungs, around smoking. I mean, what do you think?
I think what people with lived experience say is that scare tactics don't work, and we're very good at saying you shouldn't smoke because X, Y, and Z thing will happen, which is true. But I think what we don't do well enough, and where it really helps to have people with your type of expertise on board, is the message should be, if we do these checks, we can treat whatever's there. So and we can give you support to stop smoking if you're still smoking. And I think we don't give enough of the positive messages about what can be treated, because we're too busy giving the negative ones about what could go wrong.
What we see is through the lung cancer screening is that we have positive health impact just through the program, not only because we diagnose lung cancer earlier, but actually having those conversations with individuals about smoking cessation and positive lifestyle changes actually has longer term impacts as well.
It'd be good to talk about what the solutions are, because there are lots of ideas in the report and lots of things we can think of. And rather than focusing on screening per se, it'd be really good to think about the diagnostic and treatment pathways and what could change there. And we talked a little bit about, you know, mental health expertise in your pathways, but what else do you think could change to change the outcomes for people?
There's a few things that could be done. To start with, I think we need to give the tools and the understanding to individuals that work and care for patients with mental health illness, whether they're key workers, whether it's their primary care physicians, so they can have the discussions around lung cancer screening, smoking. Beyond equipping staff, whether that's in primary care or in mental health services, with the tools to discuss smoking, screening, smoking cessation, I think fundamentally we need to rethink and design our diagnostic pathways with patients with severe mental illness in mind, whether that's the number of appointments they get, whether that's how they're communicated with, whether that's how we engage with support their carers and supporters, to be able to facilitate patients. There are examples around the country where you have one-stop clinics where you can have several tests at once, or indeed for other people you need more time between those tests, because actually you do need to take a personalised approach to the diagnosis of lung cancer. But I think if you improve it for individuals with severe mental illness, actually taking that patient-centric approach, actually you can improve the pathway and experience for patients regardless of their background.
What other things do you think we need to change? There's the idea of integration between services, and that happens at, I think, different levels, because there's staff working in each other's pathways and having better communication with each other. But I think there's also sort of structural things and things like data, I suppose. What do you think about that?
To make a real difference, I think integration of physical and mental health during a cancer diagnostic pathway and treatment discussion is fundamental, because these are complicated decisions to make. And unless you've got the trusted individual that the person or the patient has in those discussions, then you're not going to be able to make an informed decision and actually make the best decision. I would like their key worker in the consultation with me. Have I ever seen that? No. Should we? Yes. So I think there are some parts of that whereby there's probably upskilling of some of the oncology staff, the clinical nurse specialists, who are often the point of contact, and maybe working more closely together with key workers so that there's more of a seamless trust. Because often if patients or individuals with mental health conditions know that their key worker trusts their care team that's going to look after them, and ultimately all of the changes or differences that need to happen, it's fundamentally important that we integrate services and we communicate closely. But ultimately, if we're going to close that gap and improve the care and outcomes for patients with lung cancer and severe mental illness, then we need to track that data and integrate it from primary care, from mental health services, and to secondary national data.
And I think there's a real opportunity to do that at a population level as well, so that we're actually proactively finding people who are at risk and proactively reaching out to them, because it's not something we do very well at the moment.
One of my take homes from the report is actually there isn't a single solution. There are a multitude of solutions from individual basis up to systems level, and it won't be one thing that resolves this, but lots of different things. And having that personalised approach for the patient that's in front of you ultimately will improve the long-term outcomes for these patients.
And for me, that makes it feel more manageable, because actually you're not looking at one enormous change, you're looking at lots of small changes at different parts of the system. And I think if you sort of look at the pathway and the system in that way, you can see potential for, you know, small changes everywhere that will add up to something that hopefully changes outcomes in the longer term. Thank you very much, John. That wasn't my kitchen, in case anyone's wondering, but I hope that gives you a bit of a flavour of the discussions that we had around creating the report. And actually, I hope it makes people feel that actually there is quite a lot that we can do, and a real and how important it is for us to make sure that we do think about how we redesign our pathways and how we work together in a different kind of way. I'm going to hand back to Tracy now so that we can carry on with the agenda.
Just like to say, I'll turn my camera and microphone on, but I think that film is just a wonderful conversation about really important work that we need to do across London, and I hope it's inspired colleagues on the call to really think about how we can take some steps to take this forward, and that will be something that we will be considering as we go forward. So I'm just going to introduce our next speaker now. and that is Gracie Tredget, who is from SLAM, the Mind and Body programme at SLAM, also linked in with King's Health Partners. And I think Ray is coming with you as well, Gracie. Is that correct?
That's right, Tracy. Thank you.
Thank you. Over to you two. Thank you very much. And if you could introduce Ray too, because we haven't got him on our slide. So.
Thank you so much, Tracy. I will. And thank you also just for the kind introduction. I'm really thrilled to be here. As Tracy said, I'm joining you here from King's Health Partners Mind and Body programme, where certainly over the last few years, we have been looking very closely at causes of premature mortality for people living with severe mental illness. And I'm really pleased to be joined today with Ray, who's joining us from South London and Maudsley in his role as programme lead for the Smoke Free and Healthy Hospitals programme, where we together have been working in partnership with colleagues over the last few years to look a bit more closely at what's contributing to inequalities in access and adherence to lung cancer pathways for people with SMI. So hopefully this builds a little bit on the fantastic talk you just heard, but gives a little bit of detail as to what's happening from our perspective in South East London. Next slide, please, Cheryl. Thank you. So by way of a bit of a background, I just want to kind of frame why. For us in South East London, as I've mentioned, considering things that are contributing to poor quality of life and poorer life expectancy and poorer outcomes for people with SMI is something we've been looking at very closely over the last few years. But we also have been considering what some of the conditions are that are contributing to that mortality gap. Next slide, please, Cheryl. Perhaps you have already heard the stats that we quote so often, which is that people with SMI are 5 times more likely to die prematurely than their counterparts in the general population, and that's around a 15 to 20-year age gap. But when we look more closely at what people are dying from, cancer absolutely stands out as one of the greatest causes of premature death in this population. People with SMI are 3 times more likely to die from cancer than people in the general population, and 1/3 of those cancer deaths are found to be preventable with early detection and particularly screening being the most effective method. Next slide, please, Show. When we've looked at this in South East London, we considered data over a 5-year period, and we considered actually what was the biggest cause of cancer mortality. And perhaps no surprise given why we're here, lung cancer was in fact the biggest cause of death in cancer deaths recorded for people with SMI during that period. Now, why this was of interest to us as King's Health Partners was because we have in South East London one of the largest SMI populations in the country. And so we're duty bound to consider what's happening in terms of quality of life and outcomes for the population. But when we look more closely at lung health and respiratory health in the population, we know very well from secondary care data that the highest rates of lung cancer that are diagnosed in the population are linked to smoking, so sort of around 70%, and that's increasing. What we also know from secondary care data is that smoking prevalence is exceedingly high in the SMI population, around 60 to 90%. And so it seemed very natural to us to start looking more closely at what was happening here and what we could do to understand better why diagnosis is so high in this population for lung cancer. Next slide, please. So over the last few years, we've been working in partnership with the South East London Cancer Alliance to think a little bit together about the lung cancer pathway that you've just heard Adam and Ed talking to. But actually, what's really a problem in terms of access and into that pathway, but also adhering to it in terms of getting an earlier diagnosis and being able to access treatment consistently. Next slide, please. So we are thinking together about barriers. That's very clear already from the talk we've just heard. But this study was really particularly concentrating on trying to understand, is lung cancer prevalence as high as we think it is for the SMI population? And what are the inequalities that we need to be understanding better and addressing as a system so that we can reduce unwarranted variation in lung cancer diagnosis and improve outcomes in terms of what's happening for the SMI population. So this study was a HRA approved study. We interrogated data over a 1-year period, looking at QoF data from primary care, SMI and cancer waiting time registers. And there were a variety of colleagues involved across primary, secondary care, acute care, as well as patients with lived experience who we interviewed and delivered a variety of focus groups with to understand their experiences. So my hope now, as I share the findings with you, that this is certainly of interest to you. And it's the first time we've shared this since the study's been completed. So next slide, please, Cheryl. Lung cancer prevalence was found to be double in the SMI population in South East London compared to the general population. And actually, when we looked across all types of cancers, we were able to see that it contributed to the highest rate of cancer burden, and that was contributing to higher rates of death from lung cancer in the population. Now, what you can see on the slide is the variation across the boroughs, the 6 boroughs in South East London. And despite the fact that there was variation in lung cancer prevalence, what we were able to see was that there were common denominators in what was contributing to that. So elevated smoking risk was certainly there, but there are other things as well, such as there were higher rates of lung cancer risk occurring at a younger part of the cohort, so people that are younger than the current threshold of cancer screening. And next slide, please. And there are sort of 4 areas of inequality that we have begun to hone in on as part of this work. So we've talked a bit about sort of baseline risk. We know already there are risks in place because of varying determinants of poor health that contribute to general poor health and multimorbidity burden for people with SMI. But that was equally there when we considered it in the context of lung cancer. And what that means for us is that when we're identifying patients, we need to be really, really thoughtful and careful about where we're looking for needs and what we're looking for in terms of how we're identifying and detecting patients in varying parts of our system and services, so that we're not missing people. And that we're getting the right people in the room and being able to provide that support. Now, a number of challenges existed for us there. Certainly that the data is not always complete. There are issues that we so often see in not being able to detect everybody. And so there are challenges just in being able to identify patients from the very beginning before we've even done anything. The second area, which is of particular interest for us along the pathway, speaks to detection. So how are we actually detecting lung cancer in this patient group? Now, one very positive thing to say is that we saw higher rates of GP referrals to the urgent suspected cancer pathway for this group, but we did not see a link between that and rates of detection. So actually, despite there being higher rates of primary care referrals, we didn't then see the link between that and rates of detection. Actually, it was more like 89% of the cases where people were diagnosed with lung cancer were being identified through emergency presentation, which aligns very much to what Adam just said in the talk there. The risk with that, we know, of course, is that if people are detected through emergency presentations, it's more likely that the stage of cancer is more advanced and therefore chances of survival are poorer. So that is one area for us in particular we need to be concentrating carefully. The other area that was of interest to us was around adherence. So actually what's happening as people journey into the pathway, and some of the things that we need to be careful in how we help people to navigate. And we looked at DNA rates. So the rates of people attending appointments was actually twice as likely to miss their appointments, people with SMI compared to their counterparts. So this idea around engagement and how we're supporting people to access every single component of the pathway, exactly as Adam said, is vital. So that we are not overlooking these common points of failure. And when we consulted widely about barriers, some of the things that we were told we've heard many times before, but they were definitely here in the context of lung cancer pathway. So the fact that care was fragmented, there was rigidity in terms of parts of the system and jumping between parts of the pathway or moving between parts of the pathway. And that patients and staff said to us that there were issues often in terms of trust with patients being able to engage and share what's going on, being able to participate in appointments safely, and making sure that we're making the engagement as equitable and as accessible as possible. Next slide, please. So as part of this work, there is something that will be coming out of it, a report certainly, and we'll share this after this webinar today. But I think one of the things to say, certainly for us, is that we recognise these inequalities are avoidable, and that with targeted action as a system, we really could do something here, particularly in light of the fact that national screening for lung cancer is now expanding, and there's an opportunity to do more through integrated neighbourhood health and what we're doing as a system to respond to all of that for this population. And hopefully, if we can do so, that we can accelerate earlier diagnosis and reduce avoidable mortality. Next slide, please. So I just want to say before I pass over to Ray, who's going to share an example of work from South London and Maudsley, is just smoking prevalence was really critical for us when we were looking at this. And one of the key findings was that 1 in 4 adults with SMI in South East London were found to be current smokers, which, as I said earlier in the presentation, this is actually lower than what we were expecting. It's more likely to be 1 in 2 people that smoke with SMI. So we were intrigued by this finding. What it allowed us to consider was actually what's being reported in primary care in terms of smoking status, and maybe whether that we're not capturing everybody. So there's something here in our findings which is certainly of interest to colleagues here at King's Partners about how can we be better capturing smoking status, and particularly how do we do that when national lung cancer screening is using smoking status as a way to identify people for that programme. But what I will do now is I'll hand over to Ray, who can share a bit about this pilot that's been happening at South London and Maudsley. Ray, we'll hand over to you.
Thanks, Gracie. Yes, I'm going to talk about a case study of an outreach project that we've piloted and now established as kind of routine in South London and Maudsley. Next slide, please. The reason for this slide, I won't dwell on it too much, but actually South East London were one of the pilot sites for the targeted lung health check prior to the national rollout of the lung cancer screening programme. And very early on, I was having conversations about the risk of exclusion for people that were part of high risk groups, and particularly working for the Mental Health Trust, you know, focusing on people with serious mental illness and being aware of the high smoking prevalence in those groups as well. And the reason for flagging that is because, I guess, with a clinical hat on, there's, I think, another call to action here, which is you don't always need to wait for the papers to be published. We kind of know some of this stuff anyway. Some of it isn't like groundbreaking news. We know that people are excluded, that they struggle with pathways. So try and make those conversations early, because as you can see on the right hand side of my screen, we did get there, but it took us 3 years or 3.5 years, and that was a lot of collaboration, a lot of meeting, and you know, and it was a success in the end, and I'll talk about that on the next slide. But it takes time to, despite knowing all of this stuff, to kind of get the gears moving. Next slide, please. So our model was basically based around ease and opportunity, and the ease was trying to make sure that we improved access. We wanted to make sure that the people who are potentially most at risk of lung cancer don't miss out from the national screening programme. We worked collaboratively with CELCA, who kind of coordinated training sessions with healthcare teams in the acute hospitals and in the mental health hospitals, in the homeless charities, in the hostels, to make sure that we could pre-identify, pre-screen patients. They didn't have to kind of invite themselves or make a phone call themselves, and that we could then facilitate their kind of arrival to the outreach van on the day as easily as possible. That included taxis, it included having somebody to go with. We even chucked in free lunch vouchers for people to try and sweeten the deal. But then the opportunity there was that whereas appointments are fully booked usually, we also allowed walk-ins. So we based it at the Maudsley Hospital, and that meant that when the clozapine clinic, a busy clinic that runs out of our outpatients department, we were able to ask patients that were kind of attending that we hadn't been able to reach out to in advance to say, we know that you smoke. Would you like to do this assessment, and would you like to come and get your lungs checked if your assessment is high risk? And we were also able to offer smoking cessation advice there and then. And I think usually what happens with the programs is that people get a referral onto another unknown service or another smoking stop smoking service, local authority funded. We were able to provide it ourselves. And I think that made a difference, because the early engagement and the early opportunity to speak to people and start building relationships was really, really important. In terms of impact, kind of as expected, people were more likely to need a scan, so more high risk patients. More of those scans came back with further input needed. What we did find, though, was even with all the kind of additional efforts to book taxis and book additional staff and really kind of support people and telephone calls, lots of calls and messages and whatever, we still had a 41% DNA rate. But by opening up the walk-ins, which on the day ended up accounting for more than half of the people that were scanned, we also started to reveal some of the gaps. And the main gap was that none of the people who walked in were known to Selka, which means that the data hadn't come from the GP records, either their age or their smoking status was incorrect. So they had been overlooked and they hadn't received any invites, or they wouldn't have received any invites via the usual pathway. Our learning then, I guess, is that patients really told us that they appreciated our efforts and they were pleased that we'd kind of gone, that we'd tried to enhance the pathway and tried to include them as much as possible. We also found that, of course, it was intensive and we couldn't have done this day without initially a kind of a show of willing and kind of people being interested in the work to develop it and take it forward. And of course, data, I've already mentioned the gaps in the data, but you know, the need to make sure that people aren't overlooked simply because we don't have the data, because that might never come. Our next steps have been that we viewed the day was viewed as a success. We've had our second day actually on the 1st of June where we had slightly more scans completed. We tailored the intervention slightly. I can talk about that later if people have got questions. But we've also been able to now integrate with the SLAM community smoke-free services, which have been recently commissioned by the local authority as a kind of adjunct to their services. And so although we're hosting them in our mental health trust, they're providing the remit for the local authority. And that means that we can now embed, we have control over this, we can embed routine screening for everybody that's coming into our service. And we don't have to wait for the van because we've made these connections, we've built these relationships with services. We're able to, you know, they've already said, if you have people, don't wait until the next day. There are other opportunities, and we've already supported some people. I've got some more stories to tell, but my time is short, so I'll hand back to Gracie.
Thank you, Ray. Next slide, please, Cheryl. So hopefully, just in hearing the example that Ray's given, it brings to life a little bit as to some of the things that we can do, just as you rightly said, Ray, just to be innovative in thinking in response to some of these problems and actually some of the opportunity that's afforded us, certainly in South East London, to try and show that there are gaps and there are things we can do in response to trying to close them. Hopefully this has been helpful in terms of the findings that we have shared. But I think the key message for us is that there is certainly an impact if we do nothing here. And what we want to try to do is reduce avoidable harm and reducing that unwarranted variation that we talked about, and particularly in the landscape now where there's lots of opportunity to consider early lung cancer detection and diagnosis for this population. So thank you so much for listening. And I think next slide has some resources, but I'll pop them in the chat. Thank you so much, and Tracy, I'll hand back to you.
And thank you, Gracie and Ray. Always interesting to think that when we make access more open, so your comment about walk-ins, that suddenly we find a population that we didn't know were there because we're making things easier for people. And it's the same with the smoke-free app that we provide, which is it's making it easy because it's 24-hour service. So the ease of access is a really key point here. Really, that came over very, very strongly. Thank you so much. So I'm going to move us on now to one of our other lung health screening colleagues, Amy Hemmington, who is the health promotion lead for lung cancer screening at UCLH. Thank you so much, Amy.
Thank you, Tracy, for the introduction, and thank you for the invitation to speak at this session today. It's a pleasure to be here. So I am the health promotion lead for lung cancer screening. I work for UCLH and we cover North Central London. And I'm here today to tell you a bit more about how screening works, more specifically in North Central London, but also across England. Next slide, please. So, I mean, we've already talked about this, but unfortunately, across the general population, most lung cancers are diagnosed at a late stage, so stage 3 or 4. Next slide, please. And this has led to lung cancer being the #1 cause of cancer death in England and across the world as well. And as we've heard, the rates of lung cancer diagnosis are higher in people with a serious mental illness, and they're also more likely to present later. So for this population, it's even more important that we're thinking about screening and how we can achieve equitable access. Next slide, please. So the whole goal of the screening program is to try and undo some of these statistics that we've just seen. Unfortunately, there often aren't signs of lung cancer at an early stage. They tend to appear late. And so most of the time, people don't know to present to their GP until the cancer is already quite advanced. The goal of the program, the screening program, is to try and identify lung cancer earlier when we have more treatment options and there's a higher chance of survival. Next slide, please. So where did it start? It actually began with the Summit study, which ran across North Central London and North East London between December 2018 and May 2023. And this study was exploring the implementation of a lung cancer screening program in that community. And it looked at people between the ages of 55 to 77 with a smoking history, and looked at using screening in that population and the outcomes from that. So this laid the groundwork for the targeted lung health check program, which you'll notice has now been changed to lung cancer screening. And it is now one of 4 national cancer screening programs. It sits alongside bowel, breast and cervical, and it's being rolled out across the country. Next slide, please. Now, there are different programs that manage the lung cancer screening pathway across England, and they are currently at varying stages of rollout, but there is a commitment for it to be fully rolled out across the country by 2030, I think it is now. The broad shape of lung cancer screening, the program is the same across regions, but you will notice some small regional differences. For example, some have mobile scanners, some have static sites, and also the flow of the program might be different. But in terms of the broad steps, it is consistent. In North Central London, that program is delivered by UCLH. And I've included a link here where you can actually find out the local program in your area if you are outside of North Central London. Next slide, please. I thought I'd just share some key highlights in terms of the lung cancer screening program, because since starting in end of 2022, it's really come along leaps and bounds, and it's a real success story, I think. So since 2022, we've reached 50% coverage of the eligible population. This is across England. We've diagnosed 11,000 lung cancers, and 76% of those have been identified at stage 1 or 2, which is fantastic. It shows that the program is doing what it set out to do. We're finding earlier stage lung cancer, the cancers that are more easy to treat and more likely to be able to cure. Next slide, please. In North Central London, we're inviting people aged 55 to 74 with a smoking history. So either a current smoker or a past smoker. And when we say smoking, that's anything with tobacco in it. So it doesn't include vaping, but it would include cigarettes, cigars, shisha, for example. And they have to be registered with a GP. Next slide. In terms of the invitation process, we identify eligible patients through GP records based on age and smoking status. And as Gracie mentioned, this does rely on that data being accurate, which we know is not necessarily the case. Some people don't update their smoking status with their GP, and so this can be outdated and incorrect. And so, part of this work is finding ways actually to make that data more accurate, because there is the opportunity for people to fall through the cracks if this is not up to date. We're also lucky enough to be able to extract data based on learning disabilities and serious mental illness as well, which equips us with some extra knowledge about the population that we're working with, but it also means that we can analyse our uptake rates according to these populations too, which is really helpful in terms of identifying inequalities. So with this data, we then send a letter to the patient's home address with a date and time for a phone appointment. Along with that, we send out an information booklet about lung cancer screening. The invitation doesn't come from the GP. This is often something that I think people can get confused about in the community. The GP, although we extract data from the GPs, they're not managing the programme. So the letter doesn't come from your local GP. It would come from the trust that's looking after the programme in your area. So for North Central London, it comes from UCLH. Next slide, please. The first step is the phone screening. So we ask the patient about their smoking history, their general lung health, any personal or family history of cancer, as well as their ethnic background, education, height and weight. And this information gets fed into a risk model, which produces a risk score. And then if over a certain threshold, they're identified as high risk, and then they would be invited to come in for an in-person appointment. Next slide, please. So this is the nurse appointment, and for North Central London, it can happen at one of 3 sites. We don't have any mobile scanners, so the patient does need to come into one of our static sites, but we have 3 options and they can choose where they'd like to go: University College Hospital, Finchley Memorial Hospital, or the Community Diagnostic Centre at the Moorwood Green, which is in Haringey. They come along to that appointment and meet with a nurse who will go through their phone screening answers, check that nothing has changed, and measure their height, weight, and blood pressure. And they will also, if they're currently smoking, be offered very brief advice around quitting, as well as a referral to a local stop smoking service if this is something that they would like to pursue. So the last part is the scan. At this point, almost everybody will need to go on and have a scan. It's a CT scan, and it is a low-dose CT scan, which means that it uses slightly less radiation than a normal CT scan. And that will happen on the same day and at the same location as the nurse appointment. It's quick and it's painless, and people can eat, drink and drive as normal. Once they've had that scan, they go home, and then we will send them their results in the post. Next slide, please. So as well as going to the patient, the results also go to the GP so that they can update their records. There are 4 possible outcomes. So the first is no concerns. We don't see anything that we are worried about in terms of cancer on the scan. And in those situations, we will invite the person to come back for another scan in 2 years, and we will continue to scan them every 2 years until they age out of the programme. The second possible result is that we notice something on the scan that needs to be monitored. So we call this a nodule follow-up. In that situation, the patient will be invited to come back for another scan in 3 months so we can monitor that. The third possible outcome is that we do see some signs or possible signs of lung cancer. In that situation, the patient also gets a phone call to explain those results, and then we refer them on to their local trust for further tests. And the fourth possible outcome is an incidental finding. So when we scan the upper part of the body, we see the lungs, we also see the heart, which means that we are often able to diagnose or identify signs of another health condition that the patient doesn't even know that they have. And we actually do a pretty good job of that. So if we do notice any signs of another health condition, then that will be passed on to the patient's GP or trust, and they can follow up with them for further tests or diagnosis and treatment. So we know that people face barriers accessing the health system. People with mental health issues are one of those groups, and there are unfortunately several underserved groups in our population that also find it hard to access the health system. We've already spoken a lot about that today. So we are really keen to do what we can to increase access. These are some of the reasonable adjustments that we can make for people, and we encourage them to let us know what we can do in advance so that we can support them as much as possible. We're always looking for ways that we can increase the way we make accommodations, and particularly for people with a serious mental illness, we have been building off the work that Ed did with the round table and the great work that Tracy has done as well to look at projects to try and reduce some of the barriers to access and improve uptake in this population, because we do know that screening uptake is lower amongst people with an SMI diagnosis. Next slide, please. Now, just to finish off, I thought I'd go through a couple of lung cancer myths. I'm often out in the community. We do a lot of outreach work, raising awareness of the programme and also trying to bring screening into the community. So I'm often out talking to people on the ground, and these are some of the things that I often hear people say as to which they raise as barriers for not wanting or thinking that they need to participate. So I thought I'd run through some of those with you, and then if you meet anyone in the community that raises this, then you can also provide some answers. So a lot of people say that they feel healthy. They don't think they need a screening. If you click through again, show, thank you. Unfortunately, sorry?
Nothing.
Oh, unfortunately, we know that feeling healthy it actually isn't always a good sign as to whether you have cancer, because symptoms often appear late, particularly for lung cancer. Most people that we screen don't have cancer, but those that do often don't have any symptoms. And these people are actually the people that we want to be screening. The goal is to screen people that do feel healthy so that we can catch lung cancer earlier when we have more treatment options. Next slide. Lots of people say that they stopped smoking a long time ago, so they don't think that they need it. It's not for them. If you click through again. Firstly, that's great. I think it takes on average 5 quit attempts for someone to successfully stop smoking. So it's really hard, and it's a huge achievement. And I can appreciate how they might feel that they're at less risk of lung cancer because of having stopped smoking. However, we do still know that even for people who have quit, their risk of lung cancer is still elevated. And so we really still encourage people to come along for their screening. If anything, it will give them some peace of mind, hopefully. Next slide. This one I find really sad, honestly. People say that they think the damage is already done, that there's no point in coming for their screening because they've smoked for 30, 40 years, a pack a day, and they don't think anything will help them at that point. If anything, this is the group of people that we want to see most. They're the most at risk of lung cancer. And so we really want these people to be coming along for their screening. If they do have cancer and it's found to be at an early stage, that's fantastic. We have treatment options. If it's found at an advanced stage, we often still have treatment options and may be able to do something to control the spread of the cancer and improve their quality of life as well. Next slide, please. And the last one, people saying that they don't want to quit smoking, that they're healthy in every other way, and this is maybe their one pleasure or their one vice. And we say that's okay. We will always encourage people to quit smoking. Smoking is bad for your health, and there's no questions around that, but people need to make that decision themselves. So we'll offer support to help them quit, but ultimately the decision is up to them. And even if they choose not to quit smoking, they are still eligible for screening, and we still encourage them to come forward for their screening. So if you or anybody you know, anybody you work with has missed their invite letter in the post or they haven't received one, they can call or they can email the service on these contact details. It's very easy for us to just send out another invite letter. Next slide, please. And I've also just included some additional resources as well as my contact details as the health promotion lead and Paul Robinson, who's the operational manager. There's some further information and also some promotional material as well. And I think that's all from me. I'll hand back to Tracy. Thank you so
much. Thank you so much, Amy. And really good to have an overview because not everyone on the call will be aware of how lung health checks work. And again, really good at the end to hear some of the myths and some of those are barriers in a way, those myths to people accessing. So thank you for that. And we look forward to, as with all the speakers, to hearing from you at the panel discussion at the end. So I'm now delighted to introduce, for 2 reasons, Maria Hart from Oxley's, who's their tobacco dependency team lead. Delighted because I did ask her how she pronounces her name, and I think it's great to have a name called Maria. Very cheerful name. So over to you, Maria. Thank you.
Thank you so much, Tracy. I'm just trying to get my slides up. Please let me know if they have started to share.
Yep, they're there.
Thank you so much. So, and thank you for the presentation so far. It's been really interesting to listen to that. So thank you. So I was asked to talk about nicotine analog prescribing and usage in a mental health unit. So, and I always smile when I get asked to talk about it because I don't feel as we at Oxley's, I'll talk to you about Oxley's in a moment, but I don't feel as we are using it very much or very well. But it just shows what a yearning there is to get these medications in wider use and how many are still feeling quite hesitant about using them. So when I tell you how few patients at Oxley's have had those, you will be surprised knowing that these meds have been available for a while. But really just to kind of start us. Oxley's is we are a sister trust to SLAM from South East London ICB, and we have about 1,200 inpatient admissions to our acute and crisis mental health units. So we've got 3 units, and we also support one longer term supported housing unit with tobacco dependency advisors. Now on all of those sites, we have 5 advisors altogether, and the service has been established since 2021. So we sort of know what we're doing so far. We're good at using NRTs, we use vapes, and staff are very motivated and well trained to do what they do, and are getting really good results since our patients are with us for quite some time. So our average length of stay, I think, is 56 days. So patients do have a lot of input during that time. Cytosine and varenicline were both approved to go into our policy and formulary in February 2025. So we have had over a year to roll them out and start using them. So when we talk about the nicotine analogues, they are basically two different medications. One of them is cytosine, which came to the UK in 2024, which has been available over the counter in many countries, Eastern Europe and I think Canada, for quite a long time. And it took a while to just get that approved to be used in the UK. And then I'm sure many of you will be aware of Champix's name as a brand name, which was in the market from 2006 to 21, which is when it got pulled out, having had some quite controversial results on a review about suicidal intentions of people, and it got pulled quite quickly, waiting for more research and overview of the evidence, which was then concluded, and varenicline as a generic, not the brand Champix, but as a generic, was then allowed in the UK to be used in January 2025, and then a month later we included that. And the South East London ICB formulary has got both of these, varenicline and cytosine, in the formulary as well. And Champix as a brand name is now back available again since last summer. So both of these meds do have a really good efficacy for general populations. They have not been targetedly researched for our priority group, so SMI and perhaps long-term health patients. And there is still clearly some requirement for further evidence and just user feedback, which is really what I'm here to do. How does it actually work, and how can we actually improve the uptake of these medications? And there is, with the name Champix, there is still a lot of hesitation regarding the brand name and the use of that medication since the sort of alerts about risk of suicide being increased, but that is not the case. We do know that does not increase the risk of suicide. Smoking does, or quitting smoking does increase the likelihood of short-term depression. However, it is not linked with particular medications. And overall, stopping smoking improves mental health in a really tangible way. So how is cytosine then prescribed? So it is a prescription-only medicine, so it always has to be prescribed by a doctor, and for us is normally a ward doctor. So our advisors, when they speak to the patients, will identify patients that might be interested, may have tried vapes, may have tried different types of nicotine replacement therapy. They use this checklist, which I've got on the slide, which is, I think this actually comes from the drug company, but it's a really good way of just checking that this patient is suitable for administration for cytosine. And we use it as a kind of memory aid as well, for us to go through what might be the side effects and things like that, so that the patient is better better informed, and it also describes quite well what the regime of the medication is. And our pharmacy was very quick to create order sets, so the doctor just needs to tick 5 boxes and the prescription is laid out onto our e-meds really easily. So the technique, it doesn't take very long. They just need to choose a start date when their cytosine is started, and then the program is laid out in the patient's medication chart. And I've now looked at our outcomes twice, so we're talking about very small numbers. So as I said, we started giving cytosine out in February last year. So I first did a little look of 19 patients who were given cytosine between February and November last year. So 19 patients, 7 of them actually stopped the cytosine at some point during the 25-day course. And reasons were patients felt unwell, one said it was too strong, one sent home without the TTOs being given to them. One patient actually sadly died during the course, but not cytosine. He took an overdose. And one patient was asked to stop the cytosine due to abnormal ECG, although that wasn't related to the cytosine. That was a pre-existing condition, but a doctor felt unsure about continuing them. And in that cohort of 19 patients, we actually had 8 patients who managed to quit smoking. So this is when followed up for 28 days. And then 4 patients maintained their quit for up to 3 months. So that was really very, very encouraging. And we kind of took some learning from that about better information to patients about the side effects and just prepping patients a bit better as to what to expect. But I must note that out of the 8 patients who did quit after having been given cytosine, 3 of the quits were actually in the end helped to the goal with the use of NRT and vapes. So cytosine on its own wasn't quite enough, but the patient after the 25-day course still needed some more nicotine. So that was quite interesting. So feedback was that patients, either some stopped, but others didn't have side effects, immediately felt their sleep improved, food tasted better, and everybody felt less nicotine cravings. There were issues with missed doses or reluctancy to prescribe, and really challenging to take the stat dose at 2-hour intervals. So that was quite difficult. So just a couple of weeks ago, I then did another little look of cytosine use since that November date, and it really looks like we are not giving cytosine as much as we could have done. So 9 patients had it, and out of those 7 completed the course. I think 1 stopped after 1 dose because he had some rash, which probably wasn't related to cytosine. 1 patient just never started it. He changed his mind, but it was already prescribed to him. And 3 out of those 9 patients actually quit at 28 days. 1 of them has now reached a 3-month quit as well, but all 3 patients in the end quit with vapes, not with cytosine. And I do have a theory of this, and my theory is that I feel as our patient cohort, the 25-day dosage is just too short. I know that there is some evidence emerging now that cytosine would be quite safe to use for much longer periods, and it might be suitable really for this SMI population to be using it for longer term. But we can't do that until we've got firm evidence that it's safe and it's effective as well. And obviously there's cost implications equally. 4 patients went back to smoking, and out of which those 4 patients, 2 have significantly reduced their smoking, however still wear, and 1 of them still wants to make another quit attempt very soon, and 2 we lost to contact, both moved out of the area. And just to kind of highlight how difficult cytosine actually in practice can be, I've got you a drug chart image there on the screen, which just shows the different stages of cytosine, how it's been administered, prescribed and administered, and the red areas are missed doses. So this patient is very typical out of the patients who were on cytosine. Patient was already had stayed with us for 3-4 weeks, so he was no longer a section patient. He was voluntary patient who had leave during the day, so he was able to go out with a staff member or with a family member, and sometimes independently as well if he'd been quite well. So he was out in the middle of the day, he was on the ward in the morning, then he went out and then came back to the ward at dinner time. So he always seemed to miss the midday and afternoon dosage, which then meant that he still had some cravings throughout the day and continued to use his vape and an inhalator, which is not meant to happen, using cytosine after 5 days. But it's difficult to manage when patients can go to a shop. If we don't provide them with a vape, for example, they would just go to a shop and just use that anyway, because the cravings are too great. And obviously, the less you take the medication, the higher the cravings are. So there are real issues. And patients with severe mental illness on the psychiatric ward cannot self-medicate. It's not something that really kind of goes with the ethos. We have a large quantity of patients who are quite suicidal. So having medication in patients' rooms or pockets is just not something that we would be able to do. So the regime of cytosine giving this frequently is a real barrier to it being successful. And I feel as we're letting patients down is the same thing if we gave them too little NRT, patient gets then convinced that it doesn't work, which is not helpful. So all in all, I think with cytosine, the challenge is that we do ward medication rounds 3 times a day, and it's difficult to remember to give the patients extra medications in between, and we can't self-administer. And our staff are constantly changing on the ward regarding doctors, and I feel as the course is just too short. Varenicline is something that we would love to do, but we have not found one patient who would be willing to take it, which is quite surprising and disappointing. And we have had several doctors who would have been happy to prescribe it, but patients, after doing some Googling independently after an interaction with the advisor, have then got quite scared about their Google searches, because when you look into varenicline, patients are very interested about their medication. They want to know what's in it. They find AI summary of varenicline or Champix, and there is a comment that says it may make depression worse. And there is a link to NHS's own information site there as well. So that is something that has been a real barrier. But I have promised chocolates or fruits of, baskets of fruit to the first doctor who manages to prescribe it to their patient and successfully get someone to take it. So I still owe somebody the first one. Hopefully that will happen soon. But thank you.
Thank you so much, Maria. And you've outlined that this can be used very effectively, but there are still challenges around this, and raising awareness amongst medical staff and of patients who are getting this kind of information is really important. Just on a positive slant, I have 2 friends I know who have used varenicline extremely effectively and given up, and so I think we really need to keep persevering with the prescription only medicines in this population. So So thank you very much. Now, we are behind time, but we are very keen to hear from Sam Holmes and Ian Callahan from Rethink, who ran some amazing roundtables for us with people with lived experience of mental ill health and of smoking. So we are going to give you your 10 minutes. So please be assured we will. And we will then have 5 minutes, a very brief panel discussion. But we really look forward to hearing from you, Sam and Ian.
Thanks very much, Tracy. And I'm trying to load the presentation, but it seems to be sticking a little bit. Anyway, hopefully it'll appear in just a second. But I'm Ian Callahan. I'm a programme manager in the Lived Experience Insights team at the charity Rethink Mental Illness. And along with my colleagues Sam and Essin, who's also here on the call, we had the privilege of facilitating 2 lived experience roundtables in May. One online, one in our offices in central London. This is a whistle-stop tour of what we found. Absolutely fascinating, and they're resonating a lot with what presenters have already spoken about as well, which is really interesting. So the aims of the project were threefold. We wanted to gather insights from people. Why do people smoke? Why start? What makes people continue? What are the challenges with trying to stop or even to quit? We wanted to get some action ideas. We wanted to ask people what's helpful, what's not helpful, what could be helpful in helping you to quit or to stop smoking. And we also wanted to get some feedback on some resources from London Tobacco Alliance as well, to feed into and to help curate better London's Mental Health and Smoking Week. Our approach was to co-design the roundtables with 2 experts by experience, people with lived experience of severe mental illness and of smoking, either previously or current, on and off. We invited about 12 people to the online roundtable, and we had 5 people with lived experience at the in-person roundtable, and we had several outputs, all of which are on the London Tobacco Alliance website, and you can see a longer report than the slides I'm just about to present, along with outputs that included one of the co-design experts by experience is a cartoonist, and they developed some cartoons based on the conversations that we had at both of the roundtables, and they're visible for people to see on the website. We also had a graphic recorder doing some visual minutes. That's the 3-meter wide piece of paper that people might have seen. I've got a slide with that image on. So we had some very creative outputs. Creativity stretched to the actual running of the roundtables. We had some what we call topic boards, which looked at the various themes that came up during the co-design process about the reward that people get from smoking, about some of the socio-cultural factors that lead people to smoke, and some of the stresses, the environmental stresses as well. And those are just some of the questions that we asked people. So what did we find? We've analysed the data that we gathered from people at both roundtables into 4 themes for the insights: smoking as coping, regulation and relief, smoking as social connection, belonging and culture, smoking, deprivation and inequality, and that quitting is complex, emotional and non-linear. So I'll just whistle stop through these. Smoking as coping, regulation and relief. People talked about the link to stress, emotional distress, anxiety, trauma, mental health experiences. People talked a lot about smoking and neurodivergence as well, and people talked about it being embedded in routines and daily functioning as well. Smoking as social connection, belonging and culture. People talked about fitting in. People talked about when they started smoking, that it was culturally normal for them, perhaps in their families or with their peer networks. People talked about about inequalities in relation to smoking, about poverty, stress, housing insecurity, and other factors as well, and inequalities in access to support. People talked about as well. The fourth theme was that quitting is complex, emotional and non-linear, that it's difficult, that it is emotional, that there's grief, it's really straightforward, it's complex. People talked a lot about that emotional side of stopping and quitting. So, support for stopping, what's helpful and what isn't? Again, there were several themes. What's helpful in supporting stopping? People talked about, and we've heard it in some of the interventions that we've already heard about today. Ray talked about the human factors, human connection and peer support from people, the importance of understanding, relational support, support from people, other people with lived experience of smoking and stopping smoking as well. Replacing it with enjoyable activities. Somebody spoke very movingly about having got a pet or some pets that helped with distraction and with another emotional support in terms of their stopping journey as well, and flexible and personalised approaches, that there are multiple pathways that would be helpful for people to quit. What's unhelpful, there were two main themes, judgment and pressure, and Ed in the video talked about the scare tactics not necessarily working, and people did talk about health warnings alone were often viewed as ineffective, and that messaging could be background noise. Simplistic advice as well. People talked about generic recommendations that didn't reflect their own experiences and their own realities of quitting, and people used this phrase, there are just too many things that I can't do. Feedback on the resources that we looked at. I won't go through all of these, but people did respond very positively to some of the videos that we watched. People said that they wanted clear information, support options, acknowledgement of the setbacks and the grief, multiple pathways to quitting, as I mentioned. They also wanted messaging to include younger people as well, and younger people's experience, and people neurodivergent experiences as well. People were very keen to have and to avoid overly clinical language. This is, unfortunately, I don't think I can expand this any further, but if you go onto the website, you'll be able to see both. This is the visual minutes. So this is a 3 metre wide piece of paper with the description of why people smoke, what helps stop, what the barriers are, the enablers are, and what all of the benefits are to stopping smoking. On the right-hand side is the feedback from the videos and the other resources that we looked at, and you can see the individual aspects of those if you look at the carousel that's been produced from those minutes on the website. I've just got a few slides of the cartoons. This is the style of the cartoons that the Expert by Experience cartoonist produced. You'll see that they're stylized images of people with speech bubbles. So that was the beginning of our round table. I'm one of them, the person on the right there. Somebody explaining, the cartoonist explaining what they were going to do, and then some of the insights that we gathered from one of the participants at the in-person round table. And that's a picture of the literal round table in our offices with some of the conversations that were going on. And I think I've managed to do that in just about 10 minutes exactly, Tracy.
Ian, you are totally stunning, and thank you so much. Not just stunning because you've kept in on time, but the roundtables that Rethink ran for us were just so rich and so insightful, and people really engaged with them, and we appreciated it enormously. Thank you. So I've put a link in the chat to where we have hosted some of those outputs, and I know that other places are wanting to use those, so that's great. Thank you so much for all your input. And we now have 6 minutes left. I'm going to call Ed back as well, and people and our speakers too, to see if there are any questions to put to the panel. So much that we could raise. And Andrew's here, fantastic. Hello, Andrew. Andrew is our cartoonist, and I'm so glad to be able to thank him in person, because I absolutely love what you produce. Thank you, Andrew. It was exactly the kind of creative and engaging content that we wanted. Your question, Andrew, please.
It's a practical question. So this session has been recorded, has it not?
Yes.
So have I got permission to share this recording with other healthcare providers who I work with?
Of course you have. We will be sending the link out. It will be hosted on our website, and we will send the link out. And we're delighted that you're acting in that ambassadorial way. Thank you, Andrew.
Right.
And thanks for the cartoons.
Shall we do a call to action from each of us to be brief? Because I think that would be, it's been such a rich session that I think it would be great just to hear from each of us who needs to do what next. So I am going to start, and I'm going to say share this webinar widely with the people who need to see it, because hopefully it will give people a bit of a sense that there's a lot we can do to help them stop smoking, and look at the rest of the resources on the LTA website. And I'm going to hand over to you, Tracy, and then you can pass on.
I will pass on. So I think we need to convene some of our system partners and continue this discussion. I think this is a starting point, not an end point. I think we've got lots of rich content and thinking, and we need to do something about it with our partners. So that's what we will do from an LTA perspective. And I'm going to hand over to Iram, who has joined us particularly for this session. I just want to make sure that we hear your thoughts, Iram.
Thank you, Tracy. That's really kind. Hello, everyone. I'm a respiratory consultant in South East London, and I've worked across NHS England, thinking about our NHS long-term plan tobacco dependence services, and I work with Gracie and Ray as well on our kind of mind and body program, thinking about lung health, SMI, and tobacco dependence. So really great. It was a great webinar. Thank you so much. I think we need a data-informed approach across London. So where are the gaps? Where are people falling through the gaps? And of course, there will be multiple, and it would depend on the individual person and the services. And but you know, I think there are some very clear gaps where actually we don't provide a personalised, evidence-based pathway of care for people with mental ill health and tobacco dependence. And so it'd be great to do something concrete around that. Thank you.
And so I'd like to hand over to Ian actually and hear from Rethink about what they think our call to action next steps are.
I think just considering Iram's just mentioned individualised, person-centred quitting pathways, that no one size fits all. Think relationally, think about the impact that it has on people of quitting, the grief that sometimes people can go through, and think about the support, personalised, individualised support for people, meeting people where they are, and trying to not always can we, but trying to provide the support that people need.
Thank you, Ian. And I'm just looking at my agenda now. So Amy, your call to action for the group, please.
Thanks, Tracy. I'm going to go with a really simple one. Just ask people, have they had their lung cancer screening? And if they haven't, share with them why it's important. It's quick and it's easy, but it's effective. Thank you.
I like your concise approach. Thank you. So Gracie and/or Ray.
Thanks, Tracy. I will just say one. I think for me, really, there is so much that we can be doing, and I suppose my plea is just really think on after today, if you can, one thing that you could do within your service, within your role, that could really champion the conversation around how we could be doing this better as a full system. And the other thing I was going to say with this, I think, is smoking for me is not, in this case, it's not just a behaviour. It's it's an indicator of risk for people with severe mental illness. And so that will be mine as a case in point, to really think about how we can be considering that better, to give you a starting point.
Thank you, and thank you all for being so concise. Meria.
Yes, I think my message would be that people with severe mental illness do want to stop, and they try very hard every day, and things are not necessarily easy for them. So I think inviting all of the partners within a local communities, whether that's community mental health, whether that's physical health GPs and housing, and police working together. There's a lot of sort of pressure. All the different housing units that our patients go to live after discharge as well are quite difficult environments for people to remain smoke-free in. So it's just putting those different parts of that whole journey together is what's going to make a difference in the end.
Thank you, Meria. And again, thank you for all being concise. Ed, I'm just going to bring you in if you've got any final thoughts to round off our webinar today.
Well, as anyone who works with me knows, I don't do running over. So I'm just going to say a massive thank you to all the presenters and all the attendees, and really looking forward to carrying on our work together.
And likewise, thank you for all the hard work, and we look forward to taking this forward. Thank you. Bye.
Thanks, everyone.
Thank you.
Bye.
Bye.
Bye.